Dr. Berwick, welcome. Thank you for joining us. Appreciate. I don't know if there was a particular patient care or research study that kind of prompted our visit today, but happy to hear and happy to have guests with you as well joining us. I'll let you introduce all.
Perfect. Thank you. And let me pull up my slides here. Thank everybody for having me today. I'm just going to share my screen and pull them up.
And as a means of better introduction from our end, as you saw at the end of our fetal therapy conference, that Dr. Janani Jayakumaran, one of our third-year fellows, presented on first trimester GI ultrasound, and our there are, I think, 6 of our MFM fellows on the call. I want to say 4 or 5 of our MFM faculty, genetic counselors, genetic counseling students, residents and students and guest MFMs on this call. So I think Dr. Berwick joining us from Cedars Sinai MFM, and really appreciate hearing from you, and appreciate your patience on getting to hear from you.
Perfect. I'm trying to, okay, there we go. I was just trying to get that set up right on the screen so you guys see. Well, yeah, thanks. So maternal fetal medicine. Yeah, I was at Cedars Sinai the last 5 years. Now I'm with a private MFM group in Los Angeles in Pomona Valley, and happy to be here today. I know and collaborated with some of the MFMs there in the group, Dr. Roman and others. So it's a real pleasure. And I really like to follow the research out of Jefferson pretty closely. It's really always great to see. And my area of interest has been in complement. I got into this world through complement, primarily through preeclampsia and HELLP syndrome when I was a fellow. So I was an MFM fellow in Boston at Brigham and Women's, and started studying complement proteins in preeclampsia and HELLP syndrome. And then so I started learning about this other disorder, atypical HUS, which is complement-mediated disorder, and a complement-mediated TMA, which is thrombotic microangiopathy. And so started seeing some of the similarities between, particularly with HELLP syndrome and atypical HUS phenotypically, and then the role of complement also between the two is very similar. So I started, seeing some of the similarities, but also some of the differences of when do you know you have atypical HUS versus your just bread and butter HELLP syndrome or other pregnancy complications. So, excited to kind of go through this today and speak to a group. It sounds like mostly MFMs here on the call. This is a sponsored talk by Alexion Pharmaceuticals, so thank them for helping to coordinate. So we always frame it around the discussions around TMAs, as you mentioned, thrombotic microangiopathies. OBGYNs, we don't really use this term as much. A TMA means something different depending on what your specialty is. So like if you're a nephrologist, you think of the TMA on the renal biopsy. If you're a hematologist, maybe you're thinking more like TTP with, really bad peripheral cystocytes, really bad thrombocytopenia. Now, I always say that OBGYNs, we should be very familiar with the term TMA, because we see, I would argue, more TMA than any other specialty, because one of the most common TMAs in the world is HELLP syndrome. And we know that HELLP syndrome was defined as a microangiopathic hemolytic anemia with thrombocytopenia. And in the very first description of HELLP syndrome, like with Louis Weinstein, they all had schistocytes on the smear. Now we've kind of gone away from the peripheral smear and schistocytes. But the hallmark feature of HELLP syndrome is a TMA, microangiopathic hemolysis, which drives the disease process. So I think we should be familiar with the term TMA, but remembering also that it's an umbrella term. Could be HELLP, could be atypical HUS, could be TTP. And so that's kind of part of, what I want to get into, and how do you know when you have, one TMA versus another. So, say, well, what do I know? What do I look for? The hard part, I think, we have the hardest OBGYN because there's a lot of overlap between particularly preeclampsia, HELLP, atypical HUS. So outside of pregnancy, if you had someone come in and they had hemolysis and thrombocytopenia, you're not even thinking of HELLP syndrome, right? They're not pregnant. So you immediately do a workup. You're thinking TTP, atypical HUS. But when someone's pregnant or postpartum, right, we go straight to HELLP syndrome. And that will be right the vast majority of the time, right? 90%, 99% of the time, that's going to be right. But we're kind of focused on the patients who are sicker, right? Those 1%ers who they don't follow the typical pattern. They don't get, you deliver them and they don't get better. They get worse postpartum instead of better. So those are the ones that really draw our attention. But really the foundation of any TMA is, like I mentioned, microangiopathic hemolysis thrombocytopenia. So why do many people miss this in the postpartum period? Well, one, not everybody tests for hemolysis. And I don't know what your guys' practice is, but I've been at, I've been to a lot of different institutions in Oregon, Boston, Los Angeles. Every time I went somewhere new, I realized that they weren't testing for hemolysis in preeclampsia patients. And why is that? And it goes, probably, honestly, it goes back to ACOG recommendations. ACOG doesn't recommend to screen for hemolysis, right? They say if you have preeclampsia, check CBC, check your creatinine, check your liver function. Why do they leave off hemolysis? We know that's a foundational feature of HELLP syndrome, and that drives HELLP syndrome. So we would like to know if you have hemolysis or not. So many of my peers, and you guys know this, like they say, well, why? What am I going to do with an LDH? How is it going to change management? Well, it changes management a lot because you know exactly what's going to, you don't know exactly what's going to happen. You never know. But I always say, the progression. If you have a platelet count of 80,000, let's say, is it going to drop or is it going to be stable? Is it gestational thrombocytopenia or is it something more serious? Well, if your LDH is high, I use 400. If it's above 400, the platelet count's going to go down. Why? Because you have a TMA. You're kind of turning over those red blood cells, but also I'll show you later, you're also consuming platelets. So if your LDH is elevated, and then particularly if you get above 1,000, 2,000, we see in atypical HUS that the LDH is sometimes even too high to measure. So you don't know that unless you check. And people think they can just rely on the platelet count. They're like, well, if it was bad, I'm sure the platelet count would be even lower. That's true for TTP, but it's not necessarily true for atypical HUS. So the LDH kind of tells you the acuity, how bad is your hemolysis, what direction is it going to go, and it kind of tells you whether the patient's going to be going in the right direction or not. Furthermore, the LDH is just the initial test, right? You check the LDH, and a lot of people don't know what to do after that. They kind of just stop the workup. But if your LDH is elevated, then you need a haptoglobin. Like, is it red cell hemolysis, right? Because people say, well, maybe the LDH is elevated due to inflammation, ischemia. Okay, very simple. Check a haptoglobin. If the haptoglobin's low, you have red cell hemolysis. Check a peripheral smear. If you have schistocytes, it's a microangiopathic red cell hemolysis. So this is part of the workup that a lot of OBGYNs are not familiar with. They often defer to hematology, even though it's rather simple to do that approach. So that's kind of, and that's just a starting point. That kind of tells you that it kind of confirms that you have a TMA if you have a microangiopathic hemolysis. And then usually, and we know this actually, one reason I like, atypical HUS is because it's very similar, the approach to preeclampsia. It's a multi-organ systemic disease. Why is that? Because just like preeclampsia, atypical HUS is an endothelial injury-mediated disorder. So like preeclampsia is systemic, right? Because you have endothelial cells everywhere. You have systemic activation, and then you could get end organ injury in a variety of end organs, right? Atypical HUS is the same way. This is a complement-mediated TMA and endothelial disorder, and you're going to get end organ injury if it's bad enough. So you get hemolysis, thrombocytopenia, end organ injury. It could be neurologic. So actually the rate of seizure in atypical HUS is the same as the rate of seizure in preeclampsia. And this is based on data outside of pregnancy. So the rate of seizure was like 10%, which is actually similar to the rate in severe preeclampsia. Although now we're very good at preventing it with magnesium and early delivery. Then you have GI symptoms, visual symptoms, cardiovascular, pulmonary edema. So you're starting to see, and this is my bias because I think that complement is also involved in preeclampsia, and that's why they look so phenotypically similar. But the truth is atypical HUS is a whole nother level. We think HELLP syndrome is bad, but atypical HUS is far worse than HELLP syndrome, because at least with HELLP, we could deliver the patient and they get better. Atypical HUS, we deliver, they don't get better. And actually that's usually the provoking factor. Then they go on to get worse postpartum. But the dominant feature, the thing is, well, how people say, how do I separate atypical HUS from HELLP syndrome, other disorders. It's really the combination of hemolysis, thrombocytopenia, renal failure. So you guys know that a creatinine over 1.1 is, we consider that severe, right? In preeclampsia. In atypical HUS, the level shoots up really high, above 2, 3, 4, it goes up to 5. And the acuity of it is pretty remarkable. It's within like 1 day or 2 days postpartum. So it's not usually very subtle. So the creatinine shoots up postpartum. And that's already a red flag that you may have a case of atypical HUS. And like I said, you can usually identify this by day 2, day 3. So that's, I say, if you have an LDH above 1,000, you know, that's, if your upper limit of normal is 250, that's 4 times the upper limit of normal. And then if you have a creatinine above 2, we don't see that very often. And then if you see that in combination, very unusual. You actually don't see that with HELLP syndrome, but people kind of think that you do. But actually look at your HELLP syndrome patients, do a retrospective review, find out how many people have an LDH over 1,000 and a creatinine over 2, and they have that combination at 2 to 3 days postpartum. I guarantee it's gonna be close to 0, right? So when you have that pattern, you have to recognize that this is way outside the box. This is something unusual, and it might be something as rare as atypical HUS. If, you know, I say it's probably, you know, I've treated about 8 or 9 patients, and this was when I was at Cedars Sinai. We had about 6,000 deliveries per year. We had about 1 to 2 cases per year. So I think it's about 1 for every 3,000, 4,000 deliveries, which is rare, but that means you'll see it once or twice a year. And it could pop up anywhere. You don't know where it's going to pop up. It could be right at a community hospital that needs transferred in. So, you know, that's the tricky part about it. The problem, one problem is there's a big differential. And people say, well, isn't there other things? We just said TMA is an umbrella term. People hear about all these things. What about TTP, Shiga toxin? They go, oh my God, there's a big differential. And this kind of, yes, kind of emphasizes that. But okay, but there are certain things. People say, well, okay, hemolysis, renal failure, but what's the diagnostic test? Maybe just give me a complement test I can order. Unfortunately, we're not there yet. Complement biomarkers are not ready for prime time. The C3, C4 you check for lupus, they're not really useful for, and I'll kind of show you why later, because lupus is more of an immune complex driven disease and atypical HUS is not. So, you know, those C3, C4 are not going to be as helpful. Many of these cases are genetic. So 50, maybe 50% will have a genetic mutation, and then that helps you know that you have atypical HUS because you have a mutation in your complement system. But that takes some time to turn around, and it's not great for acute management. And 30 to 40% will have a negative test. So it doesn't change your clinical phenotype, right? We know that if you have the phenotype, we know that you have the disease. We know that you're predisposed because you have it. It's staring you in the face. It's just that some of those cases you have a genetic variant that you can identify, and sometimes you don't. So complement genetics are not urgent. I wouldn't use it acutely. DIC, we know you can have a consumptive coagulopathy, especially after postpartum hemorrhage. So you want to make sure that patient, a lot's going on if you have a postpartum hemorrhage, massive transfusion. So those cases are really tricky, but you let the DIC resolve, you resuscitate the patient, you give blood products, patients in the ICU, and then you start to see at day 2, day 3, you know, what kind of sorts out, you know. So DIC is always tricky. You got to let that kind of, you got to resuscitate the patient if they have DIC. Shiga toxin, usually no, you can, it's what's called, so people ask me, what's atypical HUS? What does that even mean? You know, those of us practice long enough, well, we're used to that in OBGYN. Why are we used to that in OBGYN? We had atypical preeclampsia for the longest time. People still use atypical HELLP syndrome, right? These are not real things. But in atypical HUS, actually, it does have some actual meaning. The typical HUS was diarrhea, Shiga toxin associated HUS, right? So there was an infectious trigger with the Shiga toxin E. coli. And that's going to be a different treatment, right? Supportive care, you know, antibiotics. Atypical HUS is everything that's non-diarrheal, so non-infectious. You can even say anything that's not mediated by Shiga toxin because you may have GI symptoms. But so atypical just means there was no infectious trigger. So everything that's not Shiga toxin HUS is basically atypical HUS. And that's the term. Atypical HUS is what people call complement-mediated TMA. I would view those terms as the same. They mean the same thing. It's just people like the term complement-mediated TMA because it describes the pathophysiology, whereas atypical HUS people aren't sure what it means. So you may see that change over time, that people convert to complement-mediated TMA. Then you have TTP, and TTP is, the other problem with TTP is that in the past, they were together, TTP HUS. And why was this thing TTP HUS? It's because they looked similar. They both had hemolysis thrombocytopenia. People didn't know how to tell them apart. And actually, at that point in time, there was no treatment for complement anyway. So what were you going to do different? Everybody got plasma exchange, because plasma exchange works very good for TTP. It doesn't work at all for atypical HUS. It doesn't work for HELP syndrome, right? So TTP and HUS got a divorce, right? They're separated. They're not together. Irreconcilable differences. Because, so you still see people use that term, it doesn't exist, right? TTP is mediated by a deficiency of ADAMTS13, accumulation of von Willebrand factor, and it's due to an autoantibody, and that's why plasma exchange works very well. Atypical HUS is complement mediated, not usually mediated by an autoantibody, and that's why plasma exchange is not indicated for atypical HUS. You have to target the complement system. So TTP HUS are done, they're separate, they're two different things, but that's why you still see some confusion. So, you basically have to go do your workup. Now the question is, how much is done by hematology? People say, well, who's the atypical HUS expert, right? Is it nephrology? Is it hematology? Well, actually, it kind of falls across the cut. And what if it's pregnancy associated, right? Maybe there's not a lot of MFMs who have this expertise, but I argue we should. We know these patients better than anybody. We see preeclampsia, we see HELP, we see postpartum hemorrhage, we see patients in the ICU postpartum. It's up to us to know when something is different and to push. You may think that the hematologists would be very familiar with this disease. They're not, right? Not all of them are. You would think the nephrologists are all familiar with disease, and they're not. What happens is, if you tell the nephrologist, hey, I need a consult, this patient's sick, she has renal failure due to preeclampsia, guess what? You've just biased that person. Now they're going to write in their note, renal failure due to preeclampsia. Like, what? Like, patients on dialysis, we're blaming that on preeclampsia? We already delivered the patient. So we sometimes bias. So when I consult a provider, I say, patient, yes, she had preeclampsia, but now I think she has atypical HUS. Can you please consult and weigh in on atypical HUS? And then they know the direction I want to take them. But most people don't do that, right? So, or we blame it on postpartum hemorrhage. I can explain that, postpartum hemorrhage is a problem because what do we see with massive postpartum hemorrhage? Sometimes they get massive transfusion, they're hypotensive, they get kidney injury. Why do we blame that on? We say it's acute tubular necrosis, right? Ischemic ATN. But what I find, yes, sometimes that's the case, but not all postpartum renal failure is due to ATN. If you blame all postpartum renal failure on ATN, you're going to miss atypical HUS 100%. Because if you're always saying everything is ATN every single time, and nephrologists do the same thing. Oh, okay, they had some blood loss. The key is ATN doesn't cause hemolysis and thrombocytopenia. ATN is a renal limited disease, and usually you get better. ATN shouldn't require dialysis or long-term dialysis. Those tubes should recover once you resuscitate the patient. So if your kidney function goes up and you're saying this is ischemic ATN, very simple, check an LDH, right? Go back to the LDH, go back to the platelet count. Do you see hemolysis and thrombocytopenia? That's not typical of ATN. So maybe you need a renal biopsy. Maybe you can't, maybe this patient has something more significant and you don't know that. And I've talked to many nephrologists, you can't tell the difference from ATN from complement-mediated TMA, urine output, urine sediment. You can't tell the difference. The only way is through a renal biopsy. But that's a whole nother argument. They don't always want to do a renal biopsy postpartum. But you can start to see that it's important to really take it seriously. And why, we'll get into it later, but atypical HUS causes renal failure. And if you're not, it's a complement-mediated TMA, it keeps going. If you don't stop that, you have persistent renal failure, meaning you remain on dialysis, you end up with renal transplant, and you have increased mortality. So 50% of people that get a diagnosis of atypical HUS, they end up, end-stage renal disease, dialysis, renal transplant, all because, and there was a treatment potentially that could have basically reversed all of that. So that's why it's such a huge difference, when we're talking about the approach to atypical HUS. I'll give you a case example. So 27-year-old, third trimester, she presents to the hospital, pretty healthy otherwise, severe hypertension, nausea, vomiting, right upper quadrant pain, severe hypertension. Okay, you guys are all, this is basically preeclampsia until proven otherwise, right? And I agree with that. Third trimester, but you send the lab work. Now in this case, she has hemolysis, 6 LDH, see, there you go, 1600, really high. That's unusual. That's already tells you something's pretty more serious. Creatinine 1.7, again, very unusual. And then that really high LFTs, haptoglobin was low. So schistocytes. So this person has a microangiopathic hemolytic anemia, thrombocytopenia, kidney injury. We would say she has preeclampsia and HELP syndrome, right? She has a full shebang, right? Everything. But you do start to notice that her renal failure and hemolysis are a little bit more severe than usual. So again, that's going to tell you the direction. I would predict that this patient's not going to do well postpartum. And I want to get her delivered as soon as possible. And she was delivered. And she delivered for HELP syndrome. She had a vaginal delivery. Okay. But what you notice, 1 week later, she's getting worse. 1 week, right? Now, we see a lot of HELP syndrome. We know everybody talks about postpartum preeclampsia. What is postpartum preeclampsia? For the most part, we're talking about hypertension, right? We're not talking about persistent hemolysis for 1 week. That's not postpartum preeclampsia, right? Hypertension, okay, but you should not be hemolyzing at 1 week postpartum. That's not HELP syndrome. You remove the placenta. You remove the trigger. Any TMA, the first thing is you remove the trigger. Okay, the trigger was pregnancy. The placenta, we remove the placenta. You should start getting better. And if you're getting worse, not just are you not getting better, but you're getting worse. And especially if it's hemolysis and renal failure. So here you go, LDH 2000, hemoglobin 6, creatinine 5.2. 5.2, right? That's way outside the norm. This is not due to the preeclampsia, okay? The preeclampsia didn't cause this. ATN didn't cause this. How do I know this isn't due to acute tubular necrosis? Because look, she's hemolyzing again. And you wouldn't know if you didn't check LDH. If you didn't check LDH in this, let's say you did no hemolysis workup in this case, you'd have a platelet count of 118 and you'd have a creatinine of 5.2. Every single person would call it acute tubular necrosis. So the LDH completely changes your mindset, right? So that's why people ask me, why do I need to send LDH? What does it matter? Well, here it made a tremendous difference. You knew right away that you have a TMA. So my residents and fellows know you better have an LDH if you're kind of concerned about a patient, either antepartum or postpartum. So could this be DIC? We don't think so. Coags are normal. DIC is pretty easy to rule out. Let's go the infection. You could send shigatoxin. Maybe she had some GI symptoms. Okay, that's pretty easy to send shigatoxin PCR. TTP, could it be TTP? Very unlikely, because TTP doesn't usually cause severe renal failure, and TTP tends to present antepartum, right? But you still need an ADAM TS13. I argue that MFMs should be familiar with sending an ADAM TS13. You don't need hematology to send an ADAM TS13. I send ADAM TS13 on everybody with a platelet count under 50,000, unless they have known ITP. Because everybody says, and this is a badge of honor as an attending, right? The med students all worried, hey, that patient with HELP syndrome, she delivered, her platelet count's 30,000. Do you think we should worry? Do you think we should do anything? And we're like, watch, it'll get better. Just watch, it'll get better. And we are right most of the time, and then we look really brave and smart, like, I told you it was gonna get better. But you know what? It doesn't always get better. And if it doesn't get better, then you might have TTP. That's when you know you have TTP, persistent severe thrombocytopenia that does not get better. The problem is ADAM TS13 takes some time. It could take you 5 to 7 days to get that test back. By the time you think you have TTP, you're like, you're waiting for that platelet count to go up. Now you're day 3, day 4 postpartum, and it's not going up. Now you're kind of sweating like, oh my God, I said it was going to go up. It's not going up. And you don't have any ADAM-TS13, and you have to wait for it. So the sooner you send it, the sooner you get it back. And then if it's normal, there you go, you're done. You don't have TTP. If it's low, okay, ADAM-TS13 is low, okay, you just start going plasma exchange. So that's why, MFMs, we need to be the first line. By the time you get a hematology consult, that patient is probably too sick, right? Because we don't consult them until we're really worried, and then it's too late and none of the workup has been done. Okay, so this patient, she had a normal ADAM-TS13. There's just one caveat on the TTP. Why does TTP present antepartum? And then I'll explain why atypical HUS presents postpartum. So I would say 95% of TTP is antepartum, 95% of HUS is postpartum. Why such a big difference, right? Well, TTP is accumulation of von Willebrand factor, and ADAM-TS13 cleaves these von Willebrand factor. When does von Willebrand factor increase? By like the second trimester, right? We know this from von Willebrand disease. Most type 1 von Willebrand disease is corrected by pregnancy, right? Right. So, but if you have a deficiency and you can't cleave the von Willebrands, when is it going to manifest? Probably second trimester, third trimester, because that's when they're starting to accumulate. And then they start binding platelets, right? So it's consumption of platelets. And actually, if you give a platelet transfusion, you're going to increase them more. You're making them worse. So the platelet count is 20,000. They're like, oh my God, she needs platelets. They're not going up. Let's give more platelets. Well, guess what? In TTP, they're clumping in small vessels. So the more platelets you give, you're increasing the risk of myocardial infarction, stroke, death. And I remember as a resident, I saw a patient die postpartum because the team kept transfusing the patient and they didn't know it was TTP. They just thought it was bad HELP syndrome. So really important to know the fundamentals there. And yes, these things are rare, but we're talking about maternal mortality. Well, these are patients that are easily treatable, TTP, atypical HUS, and they have a high degree of mortality. So those are two things. Yes, they're rare, but you could really dramatically change the outcome for the patient. So that's why they're so important to know. Okay, so this patient, I'll kind of also tell you why you say she has preeclampsia HELP. Now you're telling me she has atypical HUS. People all say, what are the odds of that, right? She had preeclampsia HELP. Now she has atypical HUS. Now she has a rare complement disorder. What are the odds? Like now you're saying she has some zebra diagnosis. I want to tell you why, why is that possible? It all goes back to complement, right? So I said that most atypical HUS is postpartum, 95%. Okay, so then you have to understand complement and a complement mediated TMA. Complement is your immune system, your innate immune system, right? That's your immediate response to foreign material. COVID, it was very important. There was intense complement activation with COVID before we had vaccines and antibodies, right? Before you have antibodies, which is your adaptive immunity, before you have any of that, you rely on your complement system. So like complement attack the COVID virus, right? But it's indiscriminate because it's like it's just in your immediate response. It's like attack. But what happens? You get bystander injury. So with COVID, complement starts attacking the virus. You get this, what's called the membrane attack complex, which is at the end of the cascade. You start attacking the virus. It pokes holes, destroys it, it explodes, great. But you get bystander injury. In COVID, the complement started binding to the lung epithelium, right? And you get all this membrane attack complex on the lung inflammation, lung injury, and they saw that in autopsy specimens, right? So it's a problem. So complement contributed a lot to, lung injury in COVID. Where else does complement deposit? Actually, the placenta. In preeclampsia, you see a lot of complement deposition on the placenta. Now, primarily complement binds to endothelial cells, which I said is everywhere. The kidney has a lot of endothelial cells, and it's the most vulnerable. But this is the unique concept about pregnancy. The complement system is revved up because you guys know we have foreign material in every single pregnancy, right? Not only at the placental surface, but in the circulation. You're talking about cell-free DNA, right? There's DNA, RNA flown around. So we know that in every pregnancy. But how does the body protect itself? The placenta has these complement regulators. So it's protected. We always say placenta is shielded from the immune system. So depending on what part of the immune system you're looking at, but for complement, it has all these regulators that kind of prevent excess complement activation. So the placenta can shield itself. What happens? So the complement system is revved up. There's all this foreign material in the circulation. It's being activated. The body's dealing with it. It's in balance. It's in balance, right? But what happens when you deliver the placenta? Well, one, there's a shearing, right? And you have a little bit of a release of fetal material into the circulation. So you guys know, how do we know this? Rh disease, right? Why do we give RhoGAM postpartum? Because the biggest exposure to fetal red cells is delivery, right? And that's been studied. And that's when you have, that's why, you know, you always have to check Rh status around delivery because the mom's exposed. That's also kind of when you get amniotic fluid embolism is peripartum, right? Well, for complement, it's the same problem. It's like this acute activation, potentially, and you've removed a big source of your complement regulators, which was the placenta. So you shifted the balance because complement system was there. You had all these regulators on the placenta, they're removed, but you still have the system activated. Okay, but most women don't get this condition. I just said it's really rare, 1 to 2 cases per year. So why is it that only a handful of people get this condition? And that's where the genetics come into play, right? There's complement gene mutations. People don't know they have them, right? Until you're triggered. So you start pushing the system and now you're putting some strain on the system. And guess what? The system which is activated, it's like a loop. Okay, we sense foreign material, we start activating, we start triggering, we start attacking, we start binding to endothelium. But there's a handful of complement proteins that regulate the system. They're like the off switch, right? They slow things down. And this is very similar to the coagulation cascade. Coagulation, you know, clotting, fibrinolysis, clotting, fibrinolysis has to be in balance. And guess what? If you have a factor V Leiden mutation, most of the time we say, who cares? You have a factor V Leiden mutation, right? But when you start adding risk factors, pregnancy, preeclampsia, postpartum hemorrhage, you're in the ICU, you had a surgery, and you have that one little thing on top of that, which was a factor V Leiden mutation. Maybe that was the thing that kind of, you know, the straw that broke the camel's back there, right? Like maybe that was the thing that tipped you over the edge. And that's why we find that many of these patients, they had a complement gene mutation. It was just sitting there, like a factor V Leiden, it's just sitting there. But it's not really necessary the vast majority of your life. Most cases of atypical HUS are adult onset. Average age of onset, age 30 to 40. That kind of correlates with reproductive age women. If you look at reproductive age women with a diagnosis of atypical HUS, over half of them were diagnosed following pregnancy, right? So pregnancy is a major, major cause of this condition, particularly in reproductive age women. And partly you will find if you do the genetics that they had a mutation that they didn't even know about, but you added on the triggers. And that's why I say preeclampsia, it's not surprising. Preeclampsia, this is part of my research, I can guarantee you preeclampsia has even higher degree of complement activation than normal pregnancy. So they're revved up more than anybody. So if someone's going to be predisposed to atypical HUS, it's the preeclampsia population is a setup, you know, for this to happen. And that's exactly what we see. Probably about 30% of cases are preceded by preeclampsia, but it doesn't have to be preeclampsia. We see it after postpartum hemorrhage. I've seen a case of 8-week miscarriage, uncomplicated, no hemorrhage. 2 weeks later, she was in the ER with a creatinine of 11, and it was due to atypical. 11 within 2 weeks of an 8-week miscarriage that was uncomplicated, right? And she was healthy, completely healthy. So that's the problem. It could, yes, we can say risk factors, blah, 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 but this can happen to anybody, and you don't really know it until it presents itself. Okay, I don't want to take too long. Let me just show you the pathophysiology to say, why is this happening? And this is very easy to understand because we could say this is what happened. We kind of, everybody says we don't know what happens in preeclampsia, but we do, right? Like, and obviously all the angiogenic data, SFLIP, PLGF, we know placental injury. We know a lot about preeclampsia. One thing we know about the progression, endothelial injury, endothelial activation, endothelial injury, you start binding platelets, you get recruitment of inflammatory mediators, the platelet counts start sticking, they start forming a clot in small vessels, microvascular thrombosis, right? What does that lead to? End organ injury, ischemia and end organ injury. And then what happens when the space narrows enough? The red cells try to get through, they shear, and you get schistocytes. So I could tell you this is the progress from gestational hypertension to preeclampsia to preeclampsia with severe features, which is end organ injury, to a full-blown microangiopathic hemolytic anemia, which is HELLP syndrome, right? So we know this process happens in HELLP syndrome, preeclampsia, but this is actually the fundamental process for atypical HUS, and this process is mediated by complement. The difference with preeclampsia is we don't know 100% that it's mediated by complement, whereas with atypical HUS, it's accepted that it's mediated by complement. Maybe my bias is maybe we'll actually say that complement is important in HELLP syndrome as well, but we can say for sure that this is the case with atypical HUS. So the only way to mitigate the process of this loop, this amplification loop, is by targeting the complement. It's a feed-forward cycle, just like the clotting cascade. Now someone says, well, can't you just watch and wait? Okay, if I have a couple minutes, just spare it. Like, if someone had a blood clot, DVT, let's go even more extreme, pulmonary embolism. You have a clot to the lung. Would you just wait and say maybe the body will heal itself? No, you treat right away, right? Are you going to argue maybe the genetics are normal? No. Even if the thrombophilia panel is normal, there's a clot in the lung, right? It needs to be treated. What if you have a thrombosis to the cardiac vessels, myocardial ischemia and infarction? Treat right away, right? What if you have a blood clot to the brain, a stroke? Time, right? Whenever you have a clot thrombosis to an end organ, the fundamental concept is to treat right away because time is money. The longer you wait, you get dead tissue, necrosis, right? So why, when you have a clot to the kidney, what we call thrombotic microangiopathy, and you have microvascular thrombosis, and if you do a kidney biopsy, you'll see it there, why do we wait? It's partly because people aren't familiar with it. They don't value the kidneys as much, right? The kidneys are like, you have dialysis. It's important to remember that dialysis is not a treatment, right? It helps avoid fluid overload. It helps restore electrolyte balance. It does nothing for the underlying disease. And nephrologists will tell you this too. It's buying time. Dialysis is not a treatment, but it biases us because we go, oh, well, we could just send the patient home on dialysis. Basically, you just gave up. You just gave up because you didn't explore other possibilities. And if you have a blood clot to the kidney, guess what? The kidney tissue will die. And I've seen this. Let's say you might have atypical HUS postpartum, but like that case I presented, creatinine 5.2, she clearly has atypical HUS, but people decide they don't want to treat. They don't want to give a complement inhibitor. And then they don't want to do a renal biopsy. Like, why not, right? And they say, we'll just wait and see. Well, guess what? That the tubes are dying, the kidneys dying, renal cortex, what we call renal cortical necrosis. And you know what? This thing, acute tubular necrosis, the tubes will die regardless. So acute tubular necrosis, it can be a complication of any type of thrombosis and ischemia. So atypical HUS can cause tubular necrosis, cortical necrosis. Guess what? Because that clot is just sitting there. Your GFR goes down. You're not perfusing the kidney. You can't wait because the longer you wait, the harder it is to recover the kidneys. Okay, so we talked about that. Very important not to just throw plasma exchange at it. When you look in the literature of postpartum atypical HUS, most cases receive plasma exchange. It's not correct. It's not correct. It doesn't do anything for atypical HUS. We have to get away from that. Atypical HUS, plasma exchange, very good for TTP because you have to think TTP autoantibody. Think TTP autoantibody against ADAM-TS13. Then you think atypical HUS complement-mediated TMA. Totally different. So that's what you have to remember. And that's exactly what you see. Plasma exchange works for TTP. It doesn't work for atypical HUS. The problem is, and people want to give it like 5 days. Let's give it some time. So why do people want to give plasma exchange 5 days when a patient's really sick? It's because guess what? You're exchanging the plasma. When you take someone's plasma out and you give them donor plasma exchange, guess what? The LDH and platelet count improve, right? It's not surprising because the donor plasma had pretty good LDH level. So when you check the level of LDH, you're like, ooh, the plasma exchange improved the LDH and improved the platelet count. But guess what? The creatinine doesn't improve. So, and that's the red flag. But I've seen this over and over again that people get stuck into the idea that plasma exchange is working because they saw some of the lab parameters improve. And that's kind of, so actually it can lead to, sort of false sense of security. But the truth is, if you give plasma exchange and the diagnosis is atypical HUS and you don't have TTP, you're going to have 25% that end up with end-stage renal disease, dialysis, renal transplant. 1 in 4 will die from their disease. So, you know, this is talking about maternal mortality. This is something that's very easy to diagnose and treat. It already has an FDA-approved treatment. It just has to be recognized and treated. So that's a summary. Okay, good. I hopefully saved a couple minutes there, got caught up on time. It was a lot of information, but I know you guys can handle it because you're maternal fetal medicine and you guys love all this high risk stuff. But I want to see if you guys have questions or have seen any cases related to these. So thanks for having me.
Thanks so much, Dr. Berwick. I'll open the floor to questions.
Dr. Burke, thank you so much for your talk. I just had a quick question. So are you routinely ordering LDH, like in your severe preeclampsia if you're trending health labs, or only if they're getting worse?
I send it as much as you send AST and creatinine. So why send it less? If you think about HELP syndrome, the thing that drives HELP syndrome is hemolysis. Liver enzymes don't drive HELP syndrome. Platelet count doesn't drive HELP syndrome. Microangiopathic hemolytic anemia is what drives HELP syndrome. So the LDH, you think about it, why did we add liver enzymes and platelet count as a severe feature? We did that because of HELP syndrome. Weinstein, in 1982, said we should make HELP syndrome a severe criteria for preeclampsia. He wanted that to be a severe criteria. It took 20 years. It wasn't until 2002, when you go back and look at it, platelet count wasn't added as a severe criteria until 2002. Liver enzymes also at that same time. Creatinine wasn't added until 2013, right? So the only thing left is LDH hemolysis. I've been making a push for that, right? But LDH should be checked just as much as you would check AST, ALT, creatinine, and even platelet count, I would argue, if you have severe preeclampsia, because then you're super high risk for, you know, progression of this disease.
I'll acknowledge from a, maybe I'll date myself here. I may be the only one on the call who worked with Lou while he was here at Jefferson as our chair. But appreciate he loves the fact being quoted for the coining the term HELP syndrome. So
yeah, it's like that's awesome that you got to work with him directly. I think, and I mean, you go back and he was right on, right? It's you know, many things in medicine don't stand the test of time, and people are trying to kind of take it down a little bit, you know, but people ask all the time, is HELP syndrome different than preeclampsia? It's like, my bias, this is clearly a spectrum. If you have HELP syndrome and you don't have preeclampsia, maybe actually you should broaden your workup, right? You know, maybe there are other things going on, but of course you can, just because you don't always have hypertension, right? I mean, this is the pathophysiology. When you look at biomarker studies, it's no different. So that's my belief, that this is all on a spectrum, right? And so, but people have attributed hemolysis solely to HELP. But I find, you know, we looked at our data when I was in Oregon, 10% of patients with severe preeclampsia have hemolysis. People don't even know what percent of patients with severe preeclampsia have hemolysis. It's an understudied area. And we find if you have an LDH over 400, your blood transfusion rate goes up. Why does your blood transfusion rate go up? You're destroying red cells, right? So you'll have a higher, you know, higher blood transfusion, higher rate of ICU admission, higher rate of pulmonary edema, and higher rate of kidney injury. You can't say that about LFTs, actually. You know, LFTs don't correlate as well with some of these complications, but LDH actually, when you look at it, is a very good marker for adverse maternal outcomes.
I'm looking to see if Dr. Amanda Roman or her colleague behind her, Dr. Jack Ludmere, have anything to add.
I'm sorry, I couldn't really hear the entire presentation due to being scarcity patients. Wonderful. Thank you so much, Richard.
Thank you.
No, not much to add. As far as I could hear, it's a wonderful topic. You guys know me about preeclampsia. I'm always very stressed about postpartum problems and identify other situations. Do not send patients home too soon. We need to do more investigations for other possible problems. And when we call our specialists for consultations, I don't want that you tell me the patient has preeclampsia. I want to tell me that why she has preeclampsia, or am I looking at something else that I'm missing?
Yeah. And you guys are a clinical powerhouse. I know you guys can do it. All right. I just did a twin cerclage last week, quoting your study. So you guys can make it happen. You guys have the power to change the practice.
Hey,
Thank you, Richard.
hi, Richard. Jack Ludmere here. I'm also with Amanda. I'm sorry I couldn't hear everything, but from what I heard, I really appreciate your comments and teachings. Just to tell you that I'm gonna visit with Corina tomorrow at Cornell to see her new hospital. So I will just send her your regards, probably.
Yes, yes. Karina Oxford, you said?
Yes.
Yes.
Yeah. Perfect. Yes. I'm giving a talk, I think, in a little bit. Yeah, she's great. And then they have a great, program over there. Yeah, say hello. And I remember you came out, you remember when I was at Cedars Sinai, you came out there and I enjoyed that visit. And we got some pessary, talking about all your guys' research. We got some pessaries
Okay.
going.
Yeah, unfortunately, they don't work.
I know. Occasional page. I would do like a couple a year, but I know, but I'm kind of more pro cerclage, but that's why I do a lot of cerclages, but I'm always a fan of all your guys' work.
Thank you, Richard.
Thank you.
Thank you, Dr. Berwick. This is Anna. Sorry, just one quick question. This was an amazing talk. You were saying that you use then the LDAs, you order it as we order a creatinine, hemoglobin, CBC, and use 400 then as a marker of like adverse outcome. And do you trend it? Like, we always do like a preeclampsia labs every 8 to 12 hours, or depending on how's the clinical picture. But do you trend it too?
Yeah, exactly. Because, well, why do we trend? I'm very philosophical. Why do we trend labs? We're trying to identify when the patient's getting sicker. Okay. I would argue that hemolysis will kind of precede the thrombocyte, or it's going to tell you what direction you're going to go. If you don't have hemolysis, if you just look at partial help, which I just say you either have help or you don't. If you have liver enzymes elevated, low platelet count, but you don't have hemolysis, the outcomes are far better, right? So, but if you have hemolysis and you have all three, this is where, Louis Weinstein was correct. If you have all three, you're pretty sick. But if you could take away one of those three things and tell you how the patient's going to do, it would be like, if you take away LDH, outcomes are really good. If you add LDH, outcomes are really bad. So I would love to have a marker that tells me that, right? I would love, hey, SFLIT, but guess what? SFLIT goes down right away after delivery. But, we don't really have a good marker for postpartum. But LDH is actually pretty good, because if LDH is persistent postpartum, I kind of know what's going to happen. And I love knowing what's going to happen, right? You can't predict everything, like I said, but I want to know if my patient's going to get sick. So I trend it. I just put it into the preeclampsia panel. Everywhere I've been, I just say, just add it to their panel. And then they know, and then it's just there every time.
Even if it is normal, if it was less than 400, do you continue getting it with the rest of
Yeah.
the labs?
Well,
Okay,
what if
got it.
LFTs are normal? I guess it depends.
You're right. Yeah,
Yeah.
you're right. They can always like increase.
Yeah. I mean, you've seen with LFTs, it just changes. Normal, up. And actually, I think LFTs are less useful, right? If I would actually rather just check LDH and platelet and forget the LFTs, right? Personally, right? Because what do LFTs actually do for me? What do they actually do to the patient? I can, we don't actually manage them, right? But hemolysis, we would manage completely different. So I would much rather track LDH and then add on an LFT as needed, or just track everything. I don't mind but you have to track it. You can't give up. You have to it's just systematic. If you have a systematic approach, you can prevent adverse outcomes. That's the hope, that if you just have a systematic approach, you won't miss anything. You'll catch it early. You catch it early, you diagnose early, you treat early, and you're hoping that all those things start to add up.
Thank you so much.
Thanks. We're going to transition now